So as is pretty well known, breast cancer is one of the leading causes of death among women worldwide. And in this table here, I compare the incidence and mortality rates of breast cancer between different parts of the world that are more developed or less developed. So I have here boxed Eastern Africa, where Tanzania is located. So if you were to compare the incidence rate in Eastern Africa compared to more developed regions such as Northern America and Western Europe, the incidence rate is significantly higher in these more developed regions. However, with the mortality rate is extremely similar between Eastern Africa and other developed regions. So one of the main reasons behind this big discrepancy in incidence or mortality ratio between these different regions is because a lot of individuals in Tanzania and other regions of Eastern Africa, a lot of the women do not come in for breast cancer diagnosis or screening or treatment until the breast cancer has already reached its late stages. And diagnosing breast cancer in its early stage is extremely important when treating breast cancer. So in the graph here, I show the 5-year survivalship based on the stage of breast cancer. And as you can see, the survivalship decreases significantly as the stage of breast cancer advances. Thus, early diagnosis is extremely important and a great issue in Tanzania. So my project focused on identifying factors that cause these late presentations of breast cancer. And a previous C student at ORCI a couple of years ago also looked at the epidemiological breakdown of breast cancer at ORCI, and she found that 90.7 of patients were late stage, while 9.3 were early stage. However, the factors that cause these early and late stage presentations of breast cancer still remain unclear. So the purposes of my study was to identify these factors, these patient or healthcare system factors that can ultimately be utilized to predict early and late presentations of breast cancer. Okay. So for my inclusion criteria for my sample size, it was all female breast cancer patients over the age of 18 who were referred to ORCI since January 2016. And the participants were recruited from the chemotherapy ward, outpatient clinic, inpatient clinic, and the insurance clinic. So for like a typical day, me and my research assistant who conducted the interviews, because she translated the Swahili to English interviews, we would go through the medical records of patients who were present at ORCI for that specific day, and then look for patients who are eligible. And once we found a patient who was eligible, we would approach them and ask them if they would like to participate in the study. And I was surprised to find that we had a 100% response rate, so many of the patients were very eager to participate in this study. So I have here my sample size comparison with other previous C students' data. So the first box highlighted here is my current study. So I had 22.3% were early stage, while 77.7% were late stage. And then for the second and third row, I compare my data with other C students who also looked at breast cancer. And there is, as you can see, like a discrepancy between my stage distribution and other C students. And this may be due to the fact that I was only there from June to August, so I was only able to acquire a snapshot of patients who attend ORCI. And since the stage distribution isn't uniform throughout the whole year, this might cause some deviation in the stage distribution. So in the last row, for a more accurate comparison, I looked at the stage distribution between ORCI patients, specifically from June 2017 to August 2017. So these are patients who were referred to ORCI during this time. And as you can see, there's a much less difference between my study and the June to 2017, August 2017, showing that like my data is a pretty accurate representation of the sample size. Okay. And for the in-person interviews, I first developed a questionnaire, and then I reviewed it with the head breast cancer nurse to ensure that that it was culturally competent, or if there was anything that she thought I should add. And over here is the nurse that I worked with. She was really great. And yeah, each interview lasted from like 10 to 15 minutes. And after each interview, I would review the medical record of that respective patient to validate their diagnosis date and the referral dates and treatment dates. So I have here a breakdown of some of the socio-demographic results. And part that stood out most to me was the education. So I found that a significantly greater amount of late-stage patients had no formal education. So this shows that education does play some role in motivating people or patients to come in earlier for treatment and diagnosis. And here's just a continuation of the socio-demographic characteristics. And I also found that while 75% of the late-stage patients were unemployed, 61% of early-stage patients were unemployed, so that might also go in hand with like education. And then other variables I looked into was average travel time to the closest health center and average travel time to ORCI, since ORCI is apparently like the only place where cancer patients can receive chemotherapy treatment. And on average, patients often had to travel over like 8 hours to travel to ORCI. So that's a great burden, also a financial burden as well for transportation. And in this table, I looked at some factors related to the first presentation of breast cancer. So I have here in the first box highlighted. It was interesting to find that a majority or greater amount of the late-stage patients, they noted that their first clinical symptoms was breast mass and pain, while in early-stage patients, their first clinical symptom that they noticed was breast mass. And then for the time between initial symptom recognition and first physician visit, it was interesting to find that a significantly greater amount of late-stage patients waited over almost a year before they first would go to a physician to seek treatment for their breast mass and pain. And previous journals have shown that breast cancer patients who wait over 3 months, it significantly influences their survivalship. So it is alarming to see that a lot of patients wait almost over a year before they first seek treatment. And then as for the place of first symptom presentation, a lot of the patients went to Muhimbili Hospital, a district hospital, regional hospital, or missionary hospital, and found that a lot of late-stage patients would go to a dispensary. And when they would go to a dispensary, a lot of these physicians would say that the mass was just an abscess, so they would prescribe antibiotics, preventing from the patient from seeking further care or further investigations, because then they're thinking that it's just from an infection instead of seeking more screening and diagnosis. Okay. And over here, I compared the patient factors between early stage and late stage patients. So I have here highlighted the main differences I found between early and late stage. So I found that time restraints and financial restraints significantly influenced late-stage patients from coming in earlier for treatment and diagnosis. And this may be due to transportation, as I showed before, that a lot of patients have to travel up to 8 hours to ORCI. And also, a lot of the late-stage patients believe that their initial symptoms were not serious. They might think that it will go away because I was also surprised to find that some of them went to a traditional healer, and some of them were told that, oh, if you just drink water, it'll go away, or if you take this herb, it'll go away. And also, when they go to a dispensary, as I said before, a lot of them were just given antibiotics, so they would think that the mass would go away with that too. And then here, I compared health system factors between the early and late stage groups, and the most significant findings I found was that a lot of late-stage patients cited that original hospital's failure, so this is the first hospital that they went to, or first line of care that they presented their symptoms to, failed to inform them of their biopsy requirements, and also a lack of knowledge of navigating through the referral system was a significant barrier in late-stage patients from coming in earlier. And this wasn't a variable before, the initial prescription of antibiotics and pain medication, but I found that it came up a lot during my interviews, so I included it. And this is pretty surprising because a lot of these patients, they're going to seek professional care, and these health professionals are telling them that, oh, it's just an infection and it'll go away with antibiotics. So this shows that there should be further education for these physicians, especially in rural areas, on how to identify a mass or how to refer patients for further treatment or investigation if a patient comes in with a breast mass. So in the last 2 slides, I compared the patient and health system factors. So some patients cited patient factors as the only things influencing their diagnosis delay. Some patients stated that health system factors the only case, and some stated both or even none. Okay. And So future investigations include maybe replicating the study in other underserved communities, especially here in New York or in Harlem, because there's a big African American population, and comparing these results I got in Tanzania to results I find among like African women migrants here in Harlem. And hopefully that the data that I collected here will be utilized in implementing targeted screening practices and educational programs, such as educating physicians more in like rural areas on identifying or differentiating between an abscess and a breast mass, or maybe even providing financial support for patients who live far away so they can come to ORSCI for their treatment. And some study limitations include, since I was only there from June to August, I only required like a snapshot of patients who were coming in, who were present at ORCI during that time. So I wasn't acquiring an entire sample size of patients coming in to ORCI from January through December, which might cause some deviation in my sample size. And then there's also potential for recall bias since I relied on interviewing patients, but then I also used medical records in order to validate the medical information. But yeah. So in addition to research experience, we had the opportunity to go to different clinics. So we went to Bagamoyo, which was like a rural clinic in Amana. And some interesting things I found was that I think before coming to Tanzania, I had this like impression that their healthcare system wasn't that sophisticated, or there's a lot of things that they needed to work on. But I was really surprised to find that everything was like really neat, and like some of their like medical records were like color coded, and they had like very like thorough forms, like such as the HIV form that was provided by the Ministry of Health. So it was interesting to find that they implemented this like 5S philosophy they used to optimize their workflow and efficiency. And then something else interesting I found was that they integrated family planning and religion. And I feel like that's not really seen here in New York, at least the experience I've had in clinics here. There's not much emphasis on religion with family planning, and religion does play a very important part, especially here in New York where there's so many different cultures. And then the comparison of patient bill of rights in Tanzania and New York. I saw like when we were in Amana Hospital, there was a list of bill of rights for patients and included things like right of refusal of medical treatment, right to a second opinion, right to cultural competency. And these are all things that we also value here in New York that are included in the patient bill of rights. But I found that they didn't include patient confidentiality, which maybe it's something that's just assumed there, or maybe there's not much emphasis there. And another thing that I found interesting was that there was a lot of educational programs implemented in diabetes, nutrition, and hypertension education. So there is a big focus on preventative medicine in Tanzania, since these are such big issues here in New York as well. So it was cool to see that there's also parallels in that. But yeah. But yeah, so it wasn't all work. We also did some fun. But yeah, so thank you, Dr. Solomon, for giving me the opportunity to go to Tanzania, and of course the CHASM department, and ORCI, and the nurse I worked with, and Dr. Doran, of course. And yeah, that's all.
Very interesting. Do you have any theories about why the stage shift would depend upon the season of the year? I mean, the stage, I should have said stage shift, but I mean the stage that you observe. You said it was different between June and August and other seasons of the year. Any insights into why that would be?
Let's see. I don't know if it specifically has to do with like maybe like the weather, or there's a maybe the past data that I showed were from previous years, from like 2017 or 2009 to 2006. So my data is also more recent, so it might show that there's a growing focus on like more awareness of like people coming in earlier. So maybe that's why also. But as for the seasons, that I'm not sure. Maybe like traffic, or it's winter there. I mean, their winter, which is still like 70, 80 degrees. But I don't know if that might be something. But yeah.
What are you going to do with your life, and how will this experience influence that?
I think I definitely want more international experience, and this experience has really showed me that like being more like cultural confident is like really important. Because as a future doctor, especially here in New York, there's so many different cultures here, and I think I definitely want to bring my, I guess, like future practice medicine abroad, and even maybe like integrating cancer epidemiology too, definitely. So yeah.
What do you make of the extremely high percentage of late-stage presentations at ORCI?
So like what factors cause it? Well, like for some factors may include like education, or some patient factors include like time restraints or financial restraints, because like transportation is a big factor since a lot of them are relying on bus transportation, or belief that like the initial symptom is not serious, that they think it's just like abscess or infection, or because the doctor is telling them when they're going to a dispensary that, oh, like you just take these antibiotics and it'll go away. And they're trusting this professional opinion, so yeah.
Yes. Well, it's not, but considering that ORCI's dominant mode of treatment is radiation, that many of these presenting patients at late stage have actually been referred from another location for palliative radiation treatment. So knowing something, this illustrates why it's important for epidemiologists to know something about the usual treatment of the disease they're studying. So palliative radiation is a very effective means of pain control and a variety of other things, and ORCI specializes in that. So it may skew the number or the percentage of very late stage treatable only by radiation. Because
this information, right? You have the information of the treatment of the patient.
Yeah, okay.
and so you went back and verified from the individual patient records, but much of the previous treatment that may be evident in the medical records, such as they had a lumpectomy at Mohimbili, and then they've been referred, but the data will just have the data presentation at Ocean Road, and it ignores the previous history. And so they may have had a lumpectomy at Muhimbili. It was ineffective. They now have a later stage. They go back to Mohimbili. The physicians there says, well, your tumor's not operable now. We're going to send you over to Ocean Road for palliative radiation. And the data at Ocean Road, in fact, shows that as a new presentation of cancer.
Is that true? I mean, when you say early versus late, that's not referring to the initial diagnosis?
It is.
Staged at Ocean Road.
Yeah. So when I classified the patients based on early and late, I looked
can
at
put it in
the
the registry that
first
way.
like histology report that has like the stage, not the stage that they come into ORCI with, like their first initial like diagnosis.
Which is what the registry would require. Yeah, would require.
Okay.
Other questions?
You know, three great presentations from experiences at Ocean Road. One about screening, one about the way it documents stuff in the record, and this about who comes in. Have you three talked about how to, you know, maybe bring that data together for some recommendations of how things might be better?
I like the three of the current students.
Yeah, and other people that went to Tanzania. Yeah.
Oh yeah, definitely. I think that'll definitely be interesting to see.
Yeah. But you may have, you know, you're focused on breast cancer, all three, and you may have a story to tell that would be useful to Ocean Road.
Thank you, Dr.